So, good morning. We're going to start with our very first speaker today. When we go ahead and put all of this together, it just kind of comes together partially from what you guys request in the comments. And we got requests for an update on the CARE program. And so that kind of started us down this road of thinking about maybe we need to present more this year on patient support, family support for our fellow coworkers. And then one day I was walking down the hallway and I saw this great little announcement for Grand Rounds for Pediatrics from Dr. Kimothi Cain. Unfortunately, hers actually got canceled that week, but later on she got to speak about postpartum and perinatal disorders, psychiatric disorders. So I was like, wow, this might actually be a great group of topics. So our first speaker today is Dr. Kimothi Cain. She completed medical school and the general psychiatry residency, child and adolescent psychiatry fellowship, and a consult liaison psychiatry fellowship at the University of New Mexico. Boy, that's a mouthful. She is triple board certified in adult psychiatry, child and adolescent psychiatry, and consultant liaison psychiatry. She serves as the medical director for child and adolescent psychiatry outpatient services at UNM and is the program director for the child and adolescent psychiatry fellowship here. Dr. Cain's clinical focus is perinatal and women's psychiatry, child and adolescent psychiatry, early intervention, infant mental health, primary care integration, and education. Dr. Cain is passionate about treating vulnerable families and to improve outcomes for children. So today, everybody, welcome Dr. Cain as she speaks to us today about peripartum. That's a hard word for me this morning. Mood and anxiety disorders. So welcome, Dr. Cain.
Thank you for having me. Good morning. Yes, I remember Grand Rounds was canceled. We had a lot of snow, and I don't remember why, but it seemed like a lot of people were staying home with their kids. School was canceled. So, so I was very lucky to come back and talk to our Department of Peace. So lovely to see you all today. Give it just a sec. It says my screen is loading. Success? Can you see my screen? Okay. So we're going to compress a huge chunk of our lives as women into like a 50-minute presentation, which is nearly impossible. So I'm going to highlight key factors that everyone needs to know, we all need to know in terms of identifying, assessing moms for safety, and then kind of next steps of treatment. So let's get to work. Okay. So just real quick. So we're going to go over perinatal, which is pregnancy, after pregnancy, just generally mood anxiety disorders, which present in a very unique way. And then looking at how can we identify these different conditions. Some of them are very unique and don't happen outside of pregnancy or delivery. And then what are our management steps? So no disclosures. So this is kind of in memory of COVID and so many moms who delivered on their own in hospitals, and some hospitals, one in town in particular, I saw a mother who had delivered and they separated her baby from her the entire time because they were scared of COVID. So anyway. So during this period of time, so we're looking at maternal mental health disorders and we'll fine tune it. So what that encompasses is pretty much everything you can think of. So depression, anxiety, OCD, PTSD, bipolar, kind of a unique presentation, postpartum psychosis and substance use, incredibly common during pregnancy and afterwards. And so 1 in 5 women suffer from this. So if you look in a room at the women in the room, that's extraordinary. It's an extraordinary amount of women who go through this. And then in addition, kind of fine tuning towards postpartum depression or perinatal depression, it can be lethal. Mother's chance of suicide increases, and there's an increased chance of infanticide or killing their little one. So let's look at New Mexico. We're always somewhere special on the chart, usually 50 percentile. We have high rates of postpartum depression in New Mexico, higher than 15%. Nationally, you'll hear numbers 13 to 15%. So it's extraordinary. And there's many factors, as you probably are aware of: poverty, substance use, multi-generational trauma, limited services, on and on, that contribute to this. So this is one of my favorite slides. And when I'm teaching, I use this slide because it's so profound. It says everything that I'm trying to say in just a caption. So you look at 2 years after childbirth, after, and then 2 years before. And these are admissions for psychiatric conditions. So say suicidality, bipolar, whatever the case may be. Look at childbirth. There is an extraordinary increase in inpatient psychiatric hospitalizations after childbirth. It remains elevated for 2 years. Something is going on. So risk factors, too many to put on this page, but just wanted to point out some key risk factors, probably most of you are aware of. But one thing to point out is our teen parents under 18, very high rates of postpartum depression or peripartum depression, often PTSD. During this age of a young woman's life, it's not unusual to have coerced pregnancies. So, of course, lack of support. Traumatic birth is another one that I want to point out that I think we forget, and we often miss PTSD in some of these mothers. And of course, our moms living in poverty, moms of color. And to keep in mind, babies are in the NICU. And what a terrifying position to be in as a parent. And you have little babies around you, and some may die, and you have a lot of guilt about, did I do something wrong? So it's really important for us to keep these nuances in mind. The problem is that most of these conditions, these groups of conditions that I talked about, 75% often are not treated. They are not diagnosed for a variety of reasons. I'll talk about that briefly. So there's a stigma. There is kind of a lack of information that maybe people are telling them, oh, it's normal. You're supposed to feel sad or cry afterwards. And so the other thing really comes from us as prescribers. I, over the years, have seen adult psychiatrists who there's little to no training in perinatal psychiatry. It's not required in the curriculum. And so I have seen adult psychiatrists take a mother off of an antidepressant and shame her. And several mothers have ended up trying to kill themselves. So it's important to know there's lack of education. People may not have that in their skill set. And so they may say, as I've heard, mom came to me and said, my doctor said she's not touching me until after my pregnancy is over with. And I thought, oh my goodness. So we need to do better. So in terms of like what is failing our mothers, we definitely are part of that. This is interesting. So oftentimes in the media, there's a misportrayal of research, of medication research. And so I remember when the research came out in the headlines, SSRIs cause autism, and I gasped, and I thought, oh my gosh, how many SSRIs have I prescribed to pregnant mothers, breastfeeding moms, whatever the case may be, and went through my head thinking, okay, any of those kids have autism? And of course, none of them did. And then, of course, later, when I had a chance to read the article, it was comparing apples and oranges, and you can't compare apples and oranges. So, the way the media saw it is they tagged in this headline. We like headlines, and it was incorrect. That is not what the data showed. So, as a result, people get scared and say, "I'm not going to touch you." In the meantime, these mothers suffer terribly, as do their babies. I'm sorry, it's going crazy. This is particularly important to talk about, is we need to be aware of our women poverty, women of color. Often there's a lack of culturally appropriate healthcare, mental health care. There's so many racial biases and cultural biases, even within the healthcare system. You think of Black mothers who have higher rates of mortality after delivery, and that in part is, or greatly in part, is due to our healthcare system. They may not have transportation, they may not have childcare. There's always the fear of, if I report, for example, symptoms of postpartum OCD, which I'll tell you about, which can sound very frightening. It's not like a typical OCD. There are mothers that will not tell us, or I think, that I myself had postpartum OCD and thought I've never experienced anything like this in my life. And it was devastating. And even going to a doctor and saying that I was just borrowing trouble, I needed to, step up, and it's horrifying. So, and then some mothers who will tell you some of their thoughts are fearful that the children will be taken away. So we have so many barriers. And when I see mothers able to get care, I think sometimes it's a miracle that people are able to get care. So this is a very busy slide. And over the last few weeks, I've debated, should I show you less highlights? What should we do here? But this is so important. Every single point here is really critical. And it just shows you what happens when we don't treat this, identify it and treat it. So we know that moms who have depression, right? We know that impacts mom's ability to function, increases substance use for these moms. Oftentimes moms who have pretty profound mental health disorders have had a history of sexual abuse or trauma, or are in positions where they may not have confidence or feel empowered to seek help. It's hard to breastfeed. And then the concern about infanticide and suicide. The big part is in these babies. And so we know, looking at MRI, that there are changes in these little brains with a mother who struggled with peripartum depression, profound peripartum depression. So the hippocampal volume is reduced, the amygdala volume is increased. And amygdala, think about that, means almonds, 2 almonds in your brain. And those are fear centers, if you will. Generally reduced brain volume and brain matter density, lower birth weight, preterm, very hard bonding experiences, which puts a child, kind of a setup for a child to have mental illness in the future, depression, anxiety. They tend to develop poor social skills. So I see kids with a lot of aggression. This is the thing that breaks my heart, is some of these kids can have lower IQs. We see language delays, motor delays, social delays. And so this is not mom's fault. This is that the brain has gone astray, if you will, after pregnancy by no fault of a mother's, and maybe not having any support or any care. This is not okay. These are all areas where we could step in and intervene. The big concern is maternal suicide. And so most states do not have, when they're doing the autopsy and the reporting, they do not have a specific box, we'll call it a box, to check if it is a postpartum suicide. And so it may be suicide, but it's not postpartum suicide, or it may be an accident, or it may be something else. We have no way of knowing how many occur. However, there are certain states that have implemented this policy, and those states, when they revealed their data, it was not surprising to us that it was one of the leading causes of death within the first year of postpartum. So these are preventable. They're all preventable. Suicide can happen at any span. We tend to see it 6 to 9 months. So moms try so hard, and they get to the point where they just can't do it anymore. more. These moms tend to die from fairly lethal means. So it's very sad. So this is something we definitely can do better. So let's look a little bit at baby blues versus postpartum. Baby blues, very common. Most people will have baby blues. So we try not to say, oh, it's just normal, because what that does is it dismisses a mother's despair in that moment, or that mother is not identified, because it's like, oh, this is normal, because baby blues can progress to postpartum depression. It's really important to keep that in your mind. So the difference is, and those of you who've experienced it, you can, happens pretty soon after delivery. You could cry for no reason. You would be happy, but cry for no reason. You may be irritable. You're not sleeping well to begin with, right? You're lucky if you find a shower. And, but it doesn't impair function very much. Looking at mom's ability to take care of baby. Mom's on task. She's learning how to do this. She is, trying to keep things organized and overall doing really well. So having fatigue, kind of typical things, I guess, that you would see after you have a baby and you're up a lot at night. So this resolves fairly quickly. When it doesn't, it will be a trajectory. So starting with baby blues into postpartum depression. And usually, and if you think about the first week or two, having some of those baby blues, and then they don't go away. And so usually, although we say it, you looking at 4-week period, there's some women that we've seen actually that have dealt with this baby blues or subclinical depression for 9 months, and suddenly it hits so hard. So we just need to be aware that just because it's outside of the 4 weeks does not mean it's not postpartum depression. So especially in moms who are weaning babies, you may see, because of the changes in hormones, the drops in hormones, that it starts to emerge. The impact is significant. Mom is not able to take care of herself. Baby may not be bathed. Mom may not be bathed. They may not follow up for appointments, which I think is an area of prevention for us. When a mom doesn't show up for her follow-up appointments for her baby, that could be a warning sign. So recommendations for universal screening, both from ACOG and PSI, Postpartum Support International. And in most settings, we use the Edinburgh. I'll show you a screenshot of it in just a second. It's kind of hard to read. So just so those of you who haven't seen it can get a sense of what it looks like. And then the GAD-7, which almost everyone's seen for anxiety. Interestingly, and I didn't realize that PSI was advocating for screening this often. And it was great to see. I also know in a busy clinic with a lot of staff turnover since COVID, this can be really hard to make happen. But that's not an excuse. This is something that maybe when mom walks in the door, we give her an Edinburgh during these visits. And then in the pediatric clinic, I know several who do give this to mom. And so they check in on mom. And then when she has a follow-up after delivery, if she's in her PCP or with OB or midwife, then screening at that point. So we catch those later onset moms. This is hard to see. This is the Edinburgh. And if you can see question number 10, this is a concerning question. If mom checks yes or sometimes, if she checks yes, it's an emergency and mom needs to be triaged, either taken to the ED, come up with a very good safety plan if she has supported family members, lock up knives, put ropes up. I know this sounds horrible, but put up vitamins because you can't overdose on iron, acetaminophen, etc. And so, or like I said, the emergency room. I know beds are really tight in New Mexico. So, and I know if you live in a rural area, it's not as though you have a psychiatric hospital next to you. But it's okay to err on the side of safety and just to remind mom that we're just worried about you. Let's just have you go in and see someone in the emergency room just to make sure. We don't want anything terrible to happen. So this will be in the slide set. This is a lot of numbers, so don't worry about it. But scoring, so if we go back and we look at how to score it, as you can see, it's scored from 0 to 3 points on each item. So, so it could be from 0 to 30. So usually the cutoff that we think about is 12 points. So, and even I err on the side of 10 to 12 points, because if a mother has had a history of depression, if the symptoms are progressively worse, but she hasn't marked all the boxes yet, then that is a time where it's absolutely okay to jump in and start treating, especially when this person may not be, if you refer, say, to psychiatry, the wait list is months. So I think it's 3 months for adult. And so you're long past that window. So we're front line, and this is something that we can do. So I will often err on that side, as many perinatal psychiatrists do. When a mom scores 12, it is absolutely major depressive disorder. And at that point, you definitely need to be thinking about medication and therapy wait list. We have a list of therapists in the community that our nurses call and get updated wait times. There are a few that can see you in a month. I don't know anything about those. I don't even know if they treat mothers. But just at least 6 months to 9 months. So it's not okay just to say refer for therapy, refer for psychiatry. It's just not going to happen right away. So, and then again, if you have a positive question number 10, that's when you need to consider an emergency evaluation. So steps: assess for severity, just like we did. We talked about that. Make sure, talk about substances, make it safe to talk about that. Really be compassionate and say, I can imagine, or I know how hard this is right now, wherever you're coming from. If you kind of had that experience yourself, or if you're connecting with mom, this is a really hard time, and I care about you, and you're not alone. And this does get better. This does get better with treatment. So, and then, of course, safety, right? Suicidal ideation, homicidal ideation, and very importantly, if she's hearing things, seeing things, has any scary thoughts about baby being possessed, or baby who's been misplaced with someone else's baby, and sometimes I'll chuckle with moms and say, these things sound horrible, but these things happen to moms. Amazing moms can have these experiences that they will see a light emanating from their baby. And it's because of what happens with our hormones afterwards. And approaching it that way, rather than you have thoughts of killing your baby, who's going to say yes, right? That's shameful to most mothers. So trying to tease that out in that quick little sentence will take you 20 seconds. Looking at all the support options in your community, family support is key. Bringing dad or partner in is key. It's predictive. If a father, or usually it's fathers, the research shows, if a father or a partner has developed peripartum depression, I'll talk about that to get a mother well is so hard. It's so hard. So we know we also need to talk about dad. And so whether having dad come in and meet with us briefly, even calling him on the phone, whatever the case may be, start a connection so that he knows his role is so important, and that men have postpartum depression. Looking at risk and benefits, we'll talk about that. And most importantly, look at the patient preference. If she is concerned that her depression is starting after delivery, and she's had profound depression, and she wants to start back on a medication, an antidepressant, just start it. Don't say, oh, the safest one is sertraline. It's the one we know that has the least amount of medication into breast milk. We know that what happens is that we will get a mom on that. It may not work, and we have to titrate her up. Sertraline takes a little while to titrate up, and we've missed opportunities of time for bonding, having to start another trial of a medication. If a mom has a preference, we need to follow that. Some mothers will not want to take medication. That's certainly their preference. And so we do everything in our power to try to get them back frequently, to try to set up, whether it's groups or calls to the mom, contact her most important support people around her. This takes time. I live this, so I know this takes time. So important to talk about risk and benefits. SSRIs are the best studied medication in pregnancy. And so we need to look at medication as well as therapy, yoga, whatever it is a mom wants to do. So we have to keep in mind that no decision regarding treatment or not having treatment is risk-free. So let's talk about that. So risk and benefits. Let's talk about risk of antidepressant use during pregnancy. Here it is. In the first trimester, they're small, but inconsistent risks of birth defects. And so the one we look at is paroxetine. But in repeat studies, it hasn't come to fruition. So the question is, at this point, we just think there's inconsistent risks. If a mom is on paroxetine, would it be worth just continuing? Probably. Would it be worth maybe having a lower dose for the first trimester? Maybe. Would it be worth maybe doing fluoxetine or sertraline or whatever the first 3 months? Maybe. But talk to mom about the risks and benefits. Moms tend to know what is best for them. And so we do see the trend, not frequently, but we do, the transient neonatal symptoms. And then the risk of untreated depression is really interesting. So if you look at studies of mothers who are depressed and are not on an SSRI, and mothers who are depressed and are on an SSRI, what happened was in the studies, they realized that the outcomes were very similar. So, and even worse in undertreated depression, and really highlighted a few concerns. One is the risk of neurodevelopmental delays, because is it cortisol? Is it, we don't really know. There's something we think on a genomic level that changes during this time. And so these kids have higher rates of neurodevelopmental delays, which are not comparative to moms who with depression on antidepressants. We need to think there are risks for undertreatment or not being treated, suicide, impaired attachment, infanticide, and then possible neurodevelopmental delays versus some of the small, but the data about possible transient neonatal symptoms. And then just the one concern about paroxetine. So, excuse me. So we talked a little bit about this. This is a really good chart for your reference. And it can give you just a very brief overview of some of the literature that we have around this. Worth talking to mom. The preterm labor is recent literature came out on that and said that they have not identified preterm labor associated with that it may have been related to mom's depression with an undertreated depression. As we talked about, there are risks to undertreatment as well. And this is another busy slide, but this is a good slide to maybe print off to give you a pathway, really quick and simple, of what you need to do. So for example, if, say, does the patient have a history of taking antidepressant? Yes, prescribe the antidepressant that's worked in the past. If not, then you follow the arrows and it gives you examples of what to start and how to start it. And then, if at all possible, to try to follow up in 2 to 4 weeks. And then what to do when you follow up, if there are side effects, kind of next steps, or moms tolerate it really well, feeling a little bit better. And often with depression, people around us notice that we're better before we do. So I'll ask a patient if they're better, and they frequently will say, no, I feel horrible. And people around them will say, wow, she's not as isolative. She's able to take showers now. She's playing with babies. So keep that in mind as well. This is the big scary one. And so it's one of the few psychiatric disorders that has a very clear trigger, and that is childbirth. And there is probably some genetic predisposition. There is some genetic predisposition. So moms of first degree relatives, say sister or mom who had postpartum psychosis, have a significantly elevated risk. So 20 to 50%. Moms who've had it in the past, these moms, we often will prophylactically start treating as soon as baby's delivered with lithium or something. And so, why we know there's a strong immune component related to this, because they present with a delirium. And so, kind of waxing and waning, confusion. And so the thought is this an immune response? Also, given the genetic factors to sensitivity of hormonal receptors, estrogen and progesterone, that this does one trigger the other, we don't know. But we know this is a really complex syndrome. If you pick up and you ask those questions, that mom seems as though she seems very disorganized, talking a lot. Partner says, baby delivered, say, a week ago, and mom's kind of, I don't know what she's talking about. She doesn't make sense. She's not sleeping, acting manic-y with some psychosis, paranoia. And the psychosis is usually delusions about baby. Baby's been switched. It's not her baby. Baby is a changeling, which is a term from European literature, that the human was taken away and a fairy was left behind, that the baby will save the world. There's a lot of religious content around that. Baby's a child of God. I've heard that so many times, and will save the world, so I have to kill the baby. So these feelings, the other key is these feelings are egosyntonic. They make sense and they feel good. So if I'm having thoughts about killing my child, most of us would feel great grief and horror over that. These mothers, because they're so sick, it makes sense. And they are very motivated to follow through with that, to save the world. So it's in line with what their thoughts are. Emergency room, emergency room, emergency room. These women are high risk for suicide and killing their babies. We don't have time to go over the scope of this today. So it's not that common, 1 to 2, about 1,000. If mom does have a history of bipolar, better watch out for that. She has a big risk. And then, just kind of what we talked about, that risk of reoccurring in later pregnancies. And we definitely try to treat mom afterwards to prevent this. So in brief, there's depression, postpartum psychosis. Postpartum psychosis looks a little more like mania. There's usually delusions about hurting baby, and that feels good to her. Waxing and waning of symptoms, not making any sense, gibberish. Postpartum depression is that. It can be irritability, anger, depression, can't take care of herself or baby, suicidality. So let's briefly talk about anxiety. So given the brevity of our time, I want to talk about postpartum OCD. It is a very interesting condition, largely underreported. Estimates start at 2.5%. It's higher. And I'll tell you why. So this is what we talk about in the perinatal psychiatry world, is that these thoughts that come up after delivery that happen within the first couple of weeks can be very embarrassing. And I'll go over that. So mothers may be very apprehensive to tell their doctor, I'm having these thoughts. And so as a result, it can become very dangerous. And I've definitely seen it turn into psychosis. So let's talk about that. It's a complex etiology. We're not 100% sure, but it's an interesting presentation where there may be an imbalance of oxytocin, which we think might be a different presentation from postpartum depression. And so the other thing is, what is happening with the brain? That it's, seeing things that normally happen after delivery and baby, and maybe a mom is feeling overwhelmed, do this, but the brain is seeing what's happening as overwhelming, babies crying, overwhelming, or very threatening. So they start in the cycle of OCD, and we'll go through that quickly. Happens most frequently with the first baby. It can happen with subsequent babies. Maybe some OCD related beliefs. Some have proposed moms who have OCD, history of depression, but we don't really know. So what happens is this. They start to have these thoughts, and these thoughts can be very bizarre. So these thoughts can be, all of a sudden, I'm walking down the stairs and I see my baby drop down the stairs. So some people would say, oh, she's psychotic. That's not what this is. These mothers are not psychotic. So what they will do is they will, and this is what happened to me, I scooted my bottom down the stairs to avoid hurting my baby. And so it was so intrusive. It was horrific. Some mothers have had the experience where they don't even go in the kitchen because they have these images of stabbing their baby or putting their baby in the microwave. So they'll hide their knives. Others will have just fear of drowning their baby. They stop bathing their baby, which is a good sign. Others will have these intrusive thoughts about sexually abusing their babies, which are interesting because these mothers haven't necessarily had sexual abuse. What's key is, you can imagine, who's going to tell you these things. So I try to normalize it as much as possible. And, it's the one thing in psychiatry that I connect with my patients on to let them know that I experienced this myself. To me, that has been a moment of healing. They finally have someone to talk to, someone who went through it, who's, not crazy. And that's what a mother told me once. It's nice to know I'm not crazy. And I can talk to other mothers who they're not crazy either. I just feel I have so much relief in this moment. And so with that, and with trying to tease this out, keep in mind, these are not mothers who need to go to the emergency room, as opposed to someone who has delusions like postpartum psychosis. These mothers are hypervigilant and would do anything to protect their baby, anything. And so often these mothers, if untreated, can be at risk for killing themselves to protect their babies. It's a very sad condition. So these are ego dystonic. We talked about ego dystonic, they feel terrible. And these are some of the examples that patients have told me. And what they do to protect their little ones. So there's also things that you'll see, like you may see that they start doing more typical OCD, counting, reordering, repeating. You may see that as well. And then lastly, I want to include this because this is an under-researched, although it's starting to become researched over the last 10 years, under-researched area and not talked about. And so I think because perinatal depression has been, actresses, people in the media talk about their experience with it, it's become more acceptable than it was 10 years ago. This is far less acceptable. And some men will be shocked when I tell them that I'm worried that they have this. However, we know that 1 in 10 fathers, based on literature, experience postpartum depression and postpartum anxiety. And recent literature that came out a couple of months ago was 1 in 7. So, as we continue to research this, I think we'll have a better idea. So, we see with dads, it won't start as early as moms. So maybe 3 to 6 months. You can use Edinburgh for dads as well. And then how do dads present with depression? Maybe a little different, maybe more anger, less affectionate, withdrawing, punitive, and maybe criticism. And what that does is you can see why women may not get better who have postpartum depression and dad who has postpartum depression, because it becomes this really toxic space. So, there's some literature that looks at lower testosterone levels after delivery. Really fascinating. Change in serotonin. How does this happen? So we know there's psychosocial stressors, change in relationship. Mom is now focused on baby, right? That's what we do for survival of our babies. And maybe dad's feeling left out. Of course, dad's feeling left out. And so it's a combination. It's very complex presentation. So it's important to talk with dads and bring dads in and partners. And so whatever we can do to help this little one have every chance to live a healthy way and to prevent developing mental illnesses, substance use, anger, aggression, going down the line of juvenile justice system. This can make profound impacts. You treat dads just the same medication or therapy. A lot of dads are resistant. And so it's important to, maybe meet with dad, let him know that it's okay. See if you can find a support group for dads. That's it in a nutshell. I'm giving you a list of resources. So our perinatal psychiatry clinic at UNM, the Journeys Clinic, is a consult model. And so Dr. Higgins took over that a few years ago. I was in that clinic with Dr. Del Fabro. And so she and her fellow will do consult models. They end up taking care of very complex peripartum presentations, mom with schizophrenia, severe postpartum psychosis, complicated bipolar, but they will provide consultation for you, but they are so booked out. I will see, even though I said that there are 2 perinatal psychiatrists at UNM, there's just 2 of us. I spend most of my time in my world in child psychiatry. So my 0 to 5 clinic, I see pregnant moms, and I see moms with very little children and work on bonding assessments. But I'm booked out until April. And so when people refer to me, I don't think it doesn't make sense to say, okay, well, I'll see you in April. So we have so few resources anyway, but in New Mexico particularly so. So this is why each one of you are first line. I have some resources to help you, and I want to show you. So let's look at, the Postpartum International. Took a screenshot. And so I was on it this morning, took the screenshot for you, and realized they've added 10 different therapists on their webpage. This is just the first person who's listed. And so I'm not promoting her or anything. I'm not sure who she is, but there are now 14 therapists who are specializing in pregnancy and postpartum near the Albuquerque area. I, quite frankly, didn't know most of these. So the way you do it is get on right here, psidirectory.com, Postpartum Support International. And then immediately it will pop up and it will say find help, and you can put in your city or your zip code. I know in rural New Mexico, there's not a lot of resources, but there are several listed on here who are doing teletherapy. So I was so thrilled to see this. And it says accepting new patients 14. That's another hiccup, is that it's just hard to find someone. So I was so excited to share this information with you today. The other thing, and then I will finish, and this is on your list right here, McPap. So McPap is Massachusetts. And so this group of psychiatrists, the perinatal and child psychiatrists, are dynamos. And so they receive funding from Massachusetts, which is a wealthier state than us. And they've created this network where there's someone on call, and their primary care providers, or anyone, can call and say, this is what's happening. They can call for child psychiatry. So we have been trying to get funding to start this in New Mexico, and it's been circled around several times. And we've been trying to get some legislation passed to get money for this, so that some of us can take call and cover it, create an infrastructure. In the meantime, McPap has made wonderful products for us. So as you can see, there's the obstetric toolkit, pediatric toolkit, substance use. And so they also have presentations and webinars there. And so you can just click on this if you want the obstetric, and it gives you the Edinburgh. It gives you a medication algorithm. It gives you like hints and steps and what to do. And so definitely log on if you have a chance in the next few days, and bookmark that page, and then try to download that so you have those resources so you can know how to do this. Other options for if you're concerned and you just want to check on medications in terms of breastfeeding, these are our best resources. For general information, I love the MGH website, Mass General. And so they by far are the leaders in perinatal psychiatry, and they have researchers who will go through the literature, because we don't have time to go through all the literature every day, right? And give you updates and get on their mailing list. It's really great for women's health in general, menopause, perimenopause. So these are some really great resources that we can all use to try to help our moms. Any questions? I'm going to stop sharing real quick, but I will send the updated slides, the slides that you have. I updated this morning, so I will make sure you have access to those.
That's great. Thank you so much, Dr. Cain. We have a ton of questions, actually. A couple of them I think you just answered pretty much throughout your presentation. But let me go ahead and get a couple of them. Oh, I lost them. I had them all up here, and then of course, okay. The first one I have is, how do we reduce the stigma so that moms will reach out for help? And I think you talked about that a little bit, but are there any other strategies we can use when we're talking to moms to tell them, this is really kind of a normal thing that moms can go through. We really want you to get help. And to reassure them that their babies aren't going to be taken away. Because in the NICU, that's what we encounter a lot, is that the moms are afraid that they're going to get taken away from their babies.
Absolutely. Right. Absolutely. Provided some consultations in our NICU for moms, and we were really concerned about them. And that's a real concern. And so I really think it's important for us as leaders in this field to train people who we work with or who we supervise. Because I occasionally will get messages back, or I'll talk to a mom who said, in the NICU, our NICU, a nurse told me this, and I was kind of horrified. And I thought, oh, our NICU nurses are extraordinary. So maybe it was someone traveling, maybe it was, I'm not sure, but this misinformation that trickles through to these mothers is devastating. Like I explained, even in psychiatry, the psychiatrist will say, I'm not going to touch you until your baby's out. And so I think it's really important for us, however you look at your team and your system, to sit down with this, maybe share this presentation with them, or maybe however you want to train people from the top all the way down. And that could be like the front desk. I do trauma-informed seminars for our front desk. So they're the front line. People are coming in. Moms or dads may be screaming at them, threatening them. They're having a hard time. Their life has been really hard. And how to help them, how to help them navigate that. So starting with the top down or the bottom up, I think is really important to protect our moms.
All right. Another question. I think we're all very aware about the data that comes out about how women of color are not receiving the best care when it comes to childbirth, especially. So somebody asked, is there data on the prevalence of professional bias with women of care when they express concerns for pain, fear, and anxiety? And then what would you suggest that we do to help increase our awareness of our own biases when it comes to caring for women of color?
That is a great question. So those of you who are at UNM, I'm going to have to pull this up. We on Learning Central,
Probably, yes.
Learning Central, right? There is a module on implicit bias. And so we require all of our attendings and trainees to complete that training. And it's really interesting. It's, there are things that most people are not aware of. And there are implicit bias tests. And it's really worth maybe having a team meeting and you can do it privately. You wouldn't do it, you don't necessarily want everyone to see your answers, but it really helps you get a sense of where you are on that spectrum and where you have some maybe landmines where you need to be aware of. And the first thing we can do to address our own biases, because everyone has something, whether it's, what type of pet you like, or you don't like cats, or you don't like dogs, whatever the case may be, subtle. But that it's important first step to be aware of it. And most people are not aware of that. When we're aware of it, it's a wake-up moment to say, I was not aware I felt that way. That's one of the biggest motivations for change. And then having support around you, or maybe on your own, thinking, how can I approach this differently? So it may be worth talking with the people you work with, or just on your own, kind of trying one of the free implicit bias scales or tests online.
That's a good idea. There's also, in addition to that question, also, is there data on the increase of maternal mental health conditions if the pregnancy arises from the result of rape or incest? Mm-hmm. Are those even greater factors with these issues?
Those are enormous factors. And so, very good question. I think those are some of our biggest risk factors. The question is, we don't have a lot of data around this because rape is not always reported. Incest is kept hush-hush. And so, which is just horrific. But you think about, you have an assault and you have your baby. And all this time, you're creating this baby, and every kick is a trigger. The other thing is, some of these mothers actually will have pregnancy denial. So they could be the moms who don't know they're pregnant until, surprise, welcome baby. They may have had a history of sexual abuse, not necessarily that pregnancy, but, the brain compensates in very unusual ways to this. But those groups are very, very high risk moms. And oftentimes these moms of incest, of assault, rape happens in marriage, incest, the person is still in the house, they don't feel safe. They're not going to tell you because they're fearful that they will be killed or their baby will be hurt. So back to talking about safety and domestic violence and coming up with confidential ways of giving mom resources that someone may not know about, so she can have it with her.
That's great. We are out of time. I have more questions, but we'll go ahead and email them to you. And then we can go ahead and maybe get some answers for everybody. And that's pretty much it. Thank you, Dr. Cain. It was wonderful for everybody to hear your thoughts on this and the ways we can go ahead and help our moms more. So thank you for sharing your time with us today.
It's truly been a pleasure. And I really appreciate your time listening to my passion about this. But it's just, I've seen things go wrong so many times, including, a mother ending her life. And we all can do better. So these are just quick steps that I have found that I wish someone had taught me in adult psychiatry when I was training. So I just, over all these years, I wanted to give this to you. I do want to send the new slide set with all the contact information. Who can I send that to so you can share it with everybody?
Lauren and Tisha will go ahead and help you get the updates in and posted. And then we'll go ahead and have all that information for everybody. That'll be great.
There was a question, and I do apologize, in the original slide set about phone numbers. And then Jill Lucas, thank you for sharing National Maternal Mental Health Hotline. So awesome. Thank you. It was truly.
Thank you, everybody.